Membranous nephropathy is an immune complex glomerular disease in which immune deposits of immunoglobulin G and complement components develop predominantly beneath podocytes on the subepithelial surface of the glomerular capillary wall. Podocyte injury resulting from the immune deposits increases glomerular permeability to plasma proteins, which results in proteinuria and potentially nephrotic syndrome. Primary, or formerly called idiopathic membranous nephropathy, is an organ-specific autoimmune disease. It accounts for about 75 to 80% of patients with membranous nephropathy and typically occurs in the absence of an identifiable initiating event. Membranous nephropathy is among the most common causes of the nephrotic syndrome in adults without diabetes, accounting for up to 1/3 of biopsy diagnoses in some regions. The term MN reflects a pattern of injury found by histopathology examination of the kidney biopsy, glomerular basement membrane thickening, and subepithelial immunoglobulin containing deposits with little or no cellular proliferation or infiltration. Membranous nephropathy accounts for approximately 20 to 30% of cases of the nephrotic syndrome in white adults. A rising incidence has been reported in China, perhaps related to environmental pollution. Membranous nephropathy is seen in all ethnic and racial groups and in all sexes, but primary MN is more common in white males over the age of 40 years. MN in young females should raise the suspicion of systemic lupus erythematosus. MN is less commonly seen in children, in whom it's often associated with hepatitis B or less commonly autoimmune or thyroid disease. MN is an autoimmune disease that's characterized by thickening of the glomerular basement membrane due to subepithelial immune complex deposition. In primary MN, circulating autoantibodies bind to endogenous antigens on the surface of glomerular podocytes, activating complement and inducing podocyte injury. In secondary MN, it's thought that circulating antigens, immune complexes, or even monoclonal immunoglobulins may become planted on the subepithelial side of the glomerular basement membrane and initiate immune complex formation. The development of autoantibodies directed against endogenous or exogenous target antigens is thought to be the initial step in pathogenesis of membranous nephropathy. What exactly triggers loss of immune tolerance to these antigens and autoantibody production in MN is not known. The M-type phospholipase A2 receptor, a transmembrane receptor that's highly expressed in glomerular podocytes, is the major target antigen in human primary MN. The specific role of PLA2R in the glomerulus is not known. In the original description of PLA2R as a target antigen, circulating autoantibodies to PLA2R were identified in 26 of 37 patients with primary MN and could be associated with disease activity in patients for whom serial serum samples were available. By contrast, there was no evidence of PLA2R antibodies in serum from 8 patients with secondary MN due to systemic lupus erythematosus or hepatitis B, from 15 patients with proteinuric conditions other than MN, such as diabetic kidney disease or focal segmental glomerulosclerosis, or from 30 healthy control individuals. Classification of membranous nephropathy and conditions associated with it is important to explain. Primary membranous nephropathy is associated with anti-PLA2R antibodies in as high as 70 to 80% of patients. About 20 to 30% of MN is idiopathic. In about 5%, anti-THSD7A antibodies are encountered. Autoimmune diseases could represent one of the secondary causes, including class 5 lupus nephritis. Other autoimmune diseases encountered include rheumatoid arthritis, autoimmune thyroid disease, IG4-related systemic disease, anti-GBM and ANCA-associated cholestatic glomerulonephritis, infections including hepatitis B and C, HIV, syphilis, schistosomiasis, malignancies such as solid tumors of colon, stomach, lung, prostate, non-Hodgkin lymphoma, chronic lymphocytic leukemia, melanoma, drugs such as NSAIDs, historically gold salt use, mercury-containing compounds, D-penicillamine, sarcoidosis, anti-cationic bovine serum albumin, graft versus host disease, de novo membranous nephropathy in allograft, and fetal-maternal alloimmunization to neutral endopeptidases. Evidence has recently been obtained that both fixed and planted antigen mechanisms are involved in membranous nephropathy. Much of what we know about pathogenesis of MN derives from observations in animal models. Studies of the Hayman nephritis model of membranous nephritis in rats in the late 1970s established that the subepithelial immune deposits form in situ when circulating antibodies bind to an intrinsic antigen in the glomerular capillary wall. The antigen was subsequently identified as megalin, which is a 6 kilodalton large transmembrane receptor of the low-density lipoprotein receptor family. This exists on the basal surface of rat podocytes. Binding to circulating anti-megalin antibodies induces capping and shedding of antigen-antibody complexes where they bind to the underlying glomerular basement membrane. In this model, proteinuria is caused by antibodies in the immune deposits that overcome local complement regulatory mechanisms and activate complement in situ. Primary mechanism involves sublethal podocyte injury induced by the complement membrane attack complex C5b9, which triggers a cascade of structural and functional changes, including oxidative injury, calcium influx, activation of cytosolic phospholipase A2, production of arachidonic acid metabolites, and cytokines. Podocyte food process effacement is likely the result of the collapse of the actin cytoskeletal structures and loss of cell GBM adhesion complexes, and the loss of and displacement of slit diaphragms are associated with the onset of severe non-selective proteinuria. Podocyte injury also leads to the production of new extracellular matrix proteins that are laid down between and around the immune deposits, giving rise to the characteristic spikes and GBM thickening that are hallmarks of membranous nephropathy. The predominant autoimmune system responsible for primary membranous nephropathy is that associated with autoantibodies directed at the M-type phospholipase 2 receptor PLA2R on podocytes. Circulating anti-PLA2R antibodies are detectable in the serum of 75 to 80% of patients with primary MN. The antibodies are predominantly IgG4, and as in Hayman nephritis model, the antigen PLA2R and antibodies to PLA2R co-localize in the immune deposits in the primary membranous nephropathy. PLA2R is a transmembrane protein of the mannose receptor family. Although it has been shown to undergo constitutive endocytosis and is involved in the production of echinocanoids, reactive oxygen species, DNA damage, and cellular senescence, its role in the podocytes is unknown. Recently, antibodies to a second podocyte antigen, thrombospondin type 1 domain, containing 7A, or abbreviated as THSD7A, were identified in patients with anti-PLA2R negative membranous nephropathy. Clinical features of membranous nephropathy include the fact that it's rare in children, such as less than 5% of total cases of nephrotic syndrome. It's quite common in adults in 15 to 50% total cases of nephrotic syndrome depending on age, increasing frequency after age 40. Males, females, ratio is over 1 in favor of a higher occurrence in males. Whites are facing membranous nephropathy more than Asians. Normal or mildly elevated blood pressures may be seen at presentation. A benign urinary sediment is what we will encounter if we run a urine sediment exam. Non-selective proteinuria is important to note. There are significant tendencies for thromboembolic disease, which a general physician should keep in mind when they encounter thromboembolic events. About 70 to 80% of all membranous nephropathy cases presented with nephrotic syndrome. The remaining 20 to 30% may present with asymptomatic subnephritic proteinuria, which is defined as less than 3.5 grams per day. Proteinuria is non-selective. Microscopic hematuria is common, as high as 30 to 40%, but red cell casts are rare and suggest a different glomerular pathologic process. In primary MN, serologic tests for anti-PLA2R are positive in 75 to 80% of cases, whereas serum complement levels are normal despite evidence of interglomerular complement activation and serologic markers such as antinuclear antibodies, antineutrophil cytoplasmic antibody, rheumatoid factor to be normal or absent. At diagnosis, only 10 to 20% of membranous nephropathy patients have hypertension. Renal function is usually normal at presentation, with only a small fraction, which is less than 10%, presenting with renal impairment. These presenting features can be modulated by age or pre-existing hypertension. Tubular interstitial and vascular changes on biopsy may be related to those factors rather than the severity of the membranous nephropathy. In all patients, workup should include measurement of blood pressure, checking renal function, completing urine analysis, urine protein excretion, preferably in 24-hour urine, or urine protein creatinine ratio, serum albumin, serum cholesterol including LDL and HDL, often renal biopsy, anti-PLA2R testing, hepatitis B, hepatitis C, ANA, anti-dsDNA, complement level testing, and in selected patients who present with suspected thromboembolic events, related workup should take place. we talk about pathology of the membranous nephropathy, it includes formation of subepithelial immune complexes of IgG and complement along the outer surface of the capillary wall, in which glomeruli appear histologically normal and therefore may be mistaken for minimal change disease if only light microscopy is performed. Membranous nephropathy begins with the formation of immune complexes at the interface of the podocyte and GBM. With subsequent changes in the podocyte, deposition of new ECM material between and around the immune deposits, thickening of the GBM, which is glomerular basement membrane, and in some cases focal glomerulosclerosis, tubular atrophy, and interstitial fibrosis. Light microscopy shows glomeruli and interstitium appearing normal on light microscopy evaluation. Next stage of membranous nephropathy involves a homogeneous thickening of the capillary wall seen with light microscopy in sections stained with the hematoxylin and eosin or with periodic acid shift reagent. On silver methylamine staining, early projections of the GBM between deposits may be detected in a characteristic spike-like configuration. Later, lucencies may develop in the GBM as immune deposits are reabsorbed, resulting in craters within the thickened GBM. The podocyte response to the form of injury includes effacement of food processes visible only by electron microscopy. In general, there are no visible mesangial or endothelial cell abnormalities. The presence of significant mesangial hypercellularity suggests immune deposit formation in the mesangium and is more consistent with a secondary MN. This can be seen in class 5 lupus nephritis. In some patients with heavy proteinuria and progressive disease, glomeruli exhibit reduced podocyte numbers and areas of focal sclerosis that resemble secondary focal segmental glomerulosclerosis. These patients often have a more rapidly progressive course and poor response to therapy. These sclerotic lesions may be a consequence of glomerular hypertrophy accompanied by an inability of terminally differentiated podocytes to proliferate, leading to areas of denuded GBM attached to Bowman capsule and subsequent capillary collapses. In all glomerular diseases, tubular interstitial injury is common and correlates with both renal function and the level of proteinuria. Some studies suggest that long-term outcome correlates in general with the severity of the tubular interstitial damage. Pattern of glomerular capillary wall staining for IgG and in membranous nephropathy is characteristic and easily recognizable by immunohistologic findings. Positive staining for IgG marks the finely granular subepithelial deposits, which are present on the outer surface of all capillary walls. Predominant IgG subclass in primary MN is IgG4. Positive staining for IgG1, 3, IgA, IgM, or significant staining in the glomerular mesangium suggests lupus or other causes of secondary MN is an underlying mechanism. 22 kilodalton alpha and light chain staining are typically equal. Kappa and lambda light chain staining are typically equal, but are rare cases of MN secondary to monoclonal IgG, including anti-PLA2R, have been reported. Complement C3 is also present in most cases of active disease and usually reflects staining for C3c, a breakdown product of C3b that's rapidly cleared. Consequently, positive C3 staining probably reflects active ongoing immune deposit formation, when sought staining for C5b-9 is generally present as well, consistent with the proposed pathogenic role of C5b9 in this disease. Strong C1q staining is not typically found in primary MN and is more common in lupus-associated membranous nephropathy. Positive staining for C4d in the absence of C1q also has been described in primary MN. Another feature that helps distinguish primary and secondary MN is the presence of PLA2 staining in the immune deposits in a pattern that co-localizes with IgG in anti-PLA2 associated MN, but not in secondary MN. Thus, several histopathologic features help distinguish primary and secondary forms of membranous nephropathy. In electron microscopy, findings of subepithelial electron-dense deposits parallels IgG staining. In the primary membranous nephropathy, immune deposit formation occurs in a subepithelial distribution. Subendothelial deposits are not seen, and mesangial deposits are rare. These deposits in early stages of the disease process are homogeneous and may even be confluent in some areas. As disease persists, basement membrane material is laid down between the deposits and corresponds to the spikes seen on light microscopy with use of a silver methanamine stain and are easily visible by EM. Later, the spikes extend and deposits may become surrounded by new basement membrane-like material. In stage 4 disease, the basement membrane is overtly thickened. The deposits incorporated in it become more loosened, and the spikes are less apparent. Although clearly reflecting the duration of the disease, these GBM changes do not correlate well with clinical manifestations or outcome. The overlying podocyte food processes are effaced with condensation of actin skeleton. The filtration slits between the food processes may be occluded, and in those still open, the slit diaphragms may be displaced or disrupted. Microvillus changes of the podocyte membrane are common. Presence of tubulo-reticular inclusions in the endothelial cells is strongly suggestive of lupus-associated MN. Diagnosis and differential diagnosis of membranous nephropathy. When the initial presentation includes nephrotic syndrome, the differential diagnosis includes minimal change disease, FSGS, membranoproliferative spectrum of diseases such as C3 glomerulopathies and immune complex glomerulonephritis. Amyloidosis, light chain deposition disease, lupus nephritis, and diabetic nephropathy should also be in the differential. In the 20 to 25% of patients whose initial presentation is asymptomatic non-nephrotic proteinuria, the differential is even more extensive. Although clinical clues in proteinuric patients may increase the likelihood of one specific histologic pattern over another, confirmation that MN is the underlying cause of nephrotic syndrome generally requires a kidney biopsy. However, the diagnosis can be confidently made with a Positive serologic test for anti-PLA2R or anti-THSD7A when a biopsy cannot be performed. On the other hand, a negative test for anti-PLA2R or anti-THSD7A does not exclude primary MN. This is because a few patients may have positive glomerular staining for PLA2R or THSD7A despite negative serology. In addition, some patients have all the features of primary MN but lack the evidence of PLA2R or THS7DA. Secondary membranous nephropathy represents about 20 to 30% of all cases. Most common causes of secondary nephropathy include systemic lupus, hepatitis B, malignant neoplasms, and medications. In addition to a careful history and physical examination, appropriate laboratory evaluation for potential secondary causes should include a complement profile, antinuclear antibodies, hepatitis serology, chest radiography, stool testing for occult blood, mammography in women, and prostate-specific antigen testing with digital rectal examination in men. In women aged 20 to 50, a high index of suspicion is warranted for underlying lupus. This diagnosis can be particularly difficult to make because most of these patients have no systemic symptoms and serologic markers of systemic lupus erythematosus are often absent. Membranous lupus accounts for 8 to 27% of all cases of lupus nephritis. In adults, regardless of age, malignancy is an important cause of membranous nephropathy. The colon, kidney, and lung are the most common primary sites, and in some patients the tumor may not be evident at presentation. Although the diagnosis of PLA2R associated MN tends to exclude the concurrent existence of an associated malignancy, given the therapeutic implications regarding immunosuppression versus treatment for cancer, each case should be carefully assessed and evaluations beyond routine age-appropriate health maintenance tests considered if patients have risk factors for cancer. All PLA2R negative cases merit a more thorough search for a malignant tumor, as do patients with THSD7A associated MN. Hepatitis B virus associated MN is also a common secondary cause in countries where HBV is endemic. It can affect both adults and children who are chronic carriers of HBV. This can occur with or without a history of overt liver disease. In children, hepatitis B virus associated MN most often manifests as nephrotic syndrome and usually follows a benign course. In adults, progressive renal impairment is more common but may be prevented by treatment with an antiviral therapy and tacrolimus. MN secondary to drug usually resolves after discontinuation of the offending agent. The time to resolution, however, varies significantly from as early as 1 week for the drugs more commonly implicated today. These medications may include non-steroidal anti-inflammatory drugs, proton pump inhibitors, and so on. D-penicillamine and gold are important medications historically to note. Many other renal disorders have been seen in association with or superimposed on MN, including IgA nephropathy, FSGS, anti-GBM disease, ANCA-vasculitis, acute interstitial nephritis, and diabetic nephropathy. Clinical course and complications. The clinical course of membranous nephropathy varies widely. Spontaneous remissions in proteinuria have been reported in up to 30% of cases. As the severity of proteinuria at presentation increases, the frequency of spontaneous remission appears to decrease. Female gender and lower grade proteinuria at presentation are the only two features associated with a higher likelihood of spontaneous remission. This is likely to produce a bias in renal survival because most studies reporting 10-year outcomes in untreated patients have included those with subnephrotic proteinuria. For example, one study reported a 72% renal survival at 8 years for 100 untreated patients, but 37% of these patients were non-nephrotic at presentation, and more than 50% had less than 5 grams per day protein. In addition, deaths were excluded from the kidney survival analysis. Even so, there was a 25% end-stage renal disease rate by 8 years and almost 50% by 15 years. Thus, patients presenting with less than 3.5 grams per day of proteinuria, no RBC cast, no hypertension, normal renal function, and no systemic features suggestive of secondary cause have a relatively benign prognosis. However, these patients must be monitored. This is because up to 50% of those cases may develop non-nephrotic proteinuria at some time in the disease course. Most of them have this occurrence within the first 2 years after presentation. In summary, although most patients with MN do reasonably well long term, MN is still the second or third leading cause of ESRD in patients with primary GN. The factor still missing from the most MN survival data is the much higher than expected mortality from cardiovascular disease or thromboembolic events seen in patients who remain nephrotic. When another renal condition is superimposed on MN, there is often an associated acceleration in the rate of renal function loss. The most common conditions to consider in this setting are drug-induced interstitial nephritis, superimposed crescentic GN, including anti-GBM disease, and renal vein thrombosis. Patients with primary MN who develop ESRD are generally suitable candidates for kidney transplantation, although the disease may recur in up to 50% of them. Recurrence may be asymptomatic and found only on protocol biopsies, but those with recurrence of nephrotic syndrome have a high rate of graft loss. A high titer positive serologic test for anti-PLA2R at transplantation may forecast early recurrence. Given the wide variation in the natural history of MN, markers that predict individual outcome would be valuable. Testing for circulating PLA2R antibody has the potential to detect increases in MN immunologic activity before changes in classic laboratory parameters become apparent. Male sex and increasing age are associated with a higher risk for renal failure. Age seems to be related to the underlying pathologic process at presentation rather than the severity of disease, because age does not influence rate of deterioration in function, and the gender of the patient seems more closely related to the severity of proteinuria at presentation rather than representing an independent risk factor for progression. One of the best models to calculate risk of MN takes into consideration the initial creatinine clearance, the slope of the creatinine clearance during a fixed period, and the lowest level of proteinuria during that observation period. The risk score has reported sensitivity of 6 to 89%, specificity of 86 to 92%, and overall accuracy of 79 to 87% in validation studies. Relapse after complete remission occurs approximately in 75 to 40% of MN cases, but the timing is unpredictable. Relapses have been reported up to 20 years after primary remission. However, the majority of patients with relapse only with subnephrotic range proteinuria and will maintain stable long-term kidney function with conservative management alone. Achievement of either a complete or partial remission, however, significantly shows progression and increases renal survival. Review of 348 nephrotic patients with MN documented a 10-year renal survival in patients with a complete remission of 100%, with partial remission 90%, and with no remission only 45%. A recent update suggested durability of remission, whether complete or partial, drug-induced spontaneous, is closely related to the long-term outcome. Treatment of membranous nephropathy should be divided into two groups. The first group is non-immune suppressive therapy group. Conservative management of MN is directed at control of edema, hypertension, hyperlipidemia, and proteinuria is similar to that used for nephrotic syndrome of any etiology. Blood pressure control is important for both renal and cardiovascular protection. For patients with proteinuria of more than 1 gram per day, the target for blood pressure is 125/75, unless contraindicated for clinical reasons. Numerous studies have shown that angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are cardioprotective and can reduce proteinuria and slow progression of renal disease in both diabetic and non-diabetic patients with chronic nephropathy. A recent meta-analysis of the largest renal protection trials using ACE inhibitors showed that the degree of protection is closely correlated to the degree of proteinuria reduction. None of these studies has focused on the specific effect of renin-angiotensin blockade in MN. In secondary analysis, the number of patients with MN has been small, and although the use of ACE inhibitors have been associated with significant improvement in some series, their antiproteinuric effect was modest. When effective, the benefit of RAS blockade occurs early, usually within the first 3 months of initiation of treatment. Even patients at low risk of progression with less than 4 grams of protein per day, per definition, should be treated with an ACE inhibitor or ARB because this may reduce proteinuria and offer additional renal protection with minimal risk of significant adverse effects. Patients must also follow a low-salt diet described by 1.5 to 2 grams of sodium per day to achieve the maximum benefit from RAS blockade. Proteinuria is also an independent risk factor for cardiovascular morbidity and mortality. When proteinuria is in nephrotic range, there is a clear increase in cardiovascular risk with a 3-fold to 5-fold increase in both coronary events and death rates in this population. Patients with significant proteinuria almost always have elevated serum cholesterol and triglyceride levels. Although not proven, we recommend the use of statins to reduce low-density lipoprotein cholesterol to 100 or lower. especially if the treatment has not resulted in attaining subnephrotic range proteinuria. It's recommended that both ROS blockade and lipid control be initiated early in patients with MN. Dietary protein intake may be restricted to 0.8 gram per kilogram per day of high-quality protein with additional dietary protein to correct for urinary losses. Dietary protein restriction has been associated with reduced proteinuria 15 to 25% and slowing in renal disease progression, but has never been shown to induce a complete remission or add the effects obtained with ROS blockade. Protein restriction must be carefully monitored in nephrotic patients to avoid malnutrition. Retrospective reviews have shown that prophylactic anticoagulation is beneficial in reducing fatal thromboembolic episodes in nephrotic patients with MN without a concomitant increase in the risk of bleeding. No randomized controlled trial has ever been done. However, there is no current consensus about prophylactic anticoagulation, and no laboratory test can predict with any accuracy such an event. A thromboembolic event is more likely in certain patients, including those with severe and persistent nephrotic proteinuria over 10 grams per day, or a serum albumin under 2.5 gram per deciliter. Two additional recent clinical observations indicate that most thromboembolic events occur within the first 2 years of presentation, and there is an increasing likelihood of an event associated with progressively lower levels of serum albumin once below 3 grams per deciliter. Although there is still a tendency for nephrologists to wait until primary thromboembolic event was occurred before using anticoagulants, recent algorithms suggest that benefits of prophylactic anticoagulant therapy appear to outweigh the risks in patients with serum albumin below 2 or 2.5 gram per liter and low to intermediate risk for bleeding. Other agents that have been tried with modest effects in small numbers of patients with MN include Probocol, a lipid peroxidation scavenger, and high-dose intravenous immunoglobulin, an agent with multiple effects on antibody-mediated tissue injury. Second group of therapy approach is immunosuppressive therapy. Several regimens exist for immunosuppressive therapy. Many questions remain unresolved in this group of therapy options. Many of these issues based on clinically available evidence discussed in the Kidney Disease Improving Global Outcomes Clinical Practice Guidelines for glomerulonephritis. The current evidence suggests that specific immunosuppressive therapy should not be considered unless the patient has had persistent nephrotic range proteinuria over 4 grams per day and proteinuria has not declined more than 50% from baseline over a minimum observation period of 6 months, despite maximum antihypertensive and antiproteinuric therapy. Other suggested criteria for early intervention are the presence of severe disabling or life-threatening symptoms related to nephrotic syndrome, or rise in serum creatinine greater than 30% within 12 months. The latter needs to be documented as related to disease progression and not a complication such as renal vein thrombosis, transformation to crescentic MN variant, or interstitial nephritis from diuretics. Recent data also suggest that persistent low titers of PLA2R antibody are associated with a higher likelihood of spontaneous remission, and that very high levels of anti-PLA2R might be an indication for early intervention. In 3 randomized clinical trials of corticosteroids in primary MN treatment, the overall consensus has been no significant long-term beneficial effect on proteinuria, rate of disease progression, or renal survival. The use of oral corticosteroids as a single agent for the treatment of MN is therefore not recommended. The one exception may be the East Asian population, especially in Japanese origin, in whom long-term observational studies have indicated improvement in both proteinuria and renal function preservation with use of corticosteroids as monotherapy. Cytotoxic agents combined with corticosteroid therapy is generally what's preferred in severe persistent unresolving cases. In patients at moderate risk for progression, a significant benefit has been described with the combination of corticosteroid and cytotoxic agent, beginning with the methylprednisolone pulses 1 gram intravenously for 3 days at the start of months 1, 3, and 5, followed by oral methylprednisolone 0.4 mg per kilogram per day for 27 days, and each cycle followed by 1 month of treatment with a cytotoxic agent, such as cyclophosphamide or chlorambucil. Complete or partial remission of nephrotic syndrome has been seen in almost 80% of patients who were treated with this regimen, a 3 to 4-fold increase compared with the control group. Both progression rate and renal survival were significantly improved. Both treatment regimens were remarkably safe, although relapses were seen in about 30% of patients who were treated in 2 years. Similar results were obtained in a different RCT using this regimen to treat patients of an Asian ethnicity with MN. The most recent RCT in MN studied a select group of 108 patients with documented deteriorating renal function, described as over 20% GFR loss within 3 to 24 months of entry. It was a difficult study to complete, with trial entry taking 10 years. Of these 108 patients entered, and unfortunately only 42% had 1 year of data and less than 20% had 3 years of data. There were 117 severe adverse events reported, which included usually hematologic issues with chlorambucil group, renal function deterioration and cyclosporin group, and infections in both groups. Statistically, there was a small benefit in terms of preventing further progression in the chlorambucil corticosteroid group versus no difference between the cyclosporin compared with placebo group, a 20% differential. However, the very high dropout rate and inability to manage these therapies safely in patients with MN with significantly declining renal function should give pause to applying any of these options under these conditions. One smaller RCT using intravenous cyclophosphamide in patients at high risk for progression noted two statistical differences in proteinuria, remission rate, or rate of decline of renal function between the corticosteroid alone and the combined treatment groups. However, this RCT used monthly intravenous doses of cyclophosphamide rather than the oral regimen used in the Italian and Indian studies and in the 2013 UK trial. In older, smaller studies, these cytotoxic agents, even appropriate adjustments in dosage, have produced variable effects on outcome and significant adverse events in a high percentage of patients. The most recent longer-term studies in high-risk patients prospectively studied 65 patients with MN and serum creatinine concentration above 1.5 mg per deciliter treated with oral cyclophosphamide for 12 months plus corticosteroids. Renal survival was 86% after 5 years and 74% after 7 years. Partial remission occurred in 86% of patients. The relapse rate was similar to earlier cytotoxic corticosteroid regimens. Treatment-related complications were significant and occurred in 2/3 of patients, mainly bone marrow suppression and infections. Most adverse events could be managed by dose reduction, although some required permanent discontinuation of treatment. A meta-analysis showed that use of alkylating agents was associated with higher remission rates, but no statistical benefit of cytotoxic drug therapy was demonstrated compared with placebo in rates of ESRD or death. The difficulty with this type of analysis is that the end point of renal survival is far beyond the termination point of most clinical trials. The latest UK study, for example, had few patients still in follow-up after 3 years in any of 3 treatment groups, so it was not possible to demonstrate any effect on long-term preservation of renal function. In summary, cyclophosphamide used in combination with corticosteroids appears to be effective in treatment of patients with nephrotic range proteinuria resulting from MN, especially if renal function is well preserved at initiation of therapy. This combination may work even in those with impaired renal function, but the supporting evidence is much less compelling. Adverse effects are higher and the likelihood of benefit is reduced, especially in patients with advanced renal failure with less than GFR of 30 ml per minute. The favorable effects are maintained beyond the 1-year treatment period, but relapse rates approach 35% by 2 years. The adverse effects of long-term cyclophosphamide therapy are major drawbacks to the universal application of this treatment. These include increased susceptibility to infections, anemia, thrombocytopenia, nausea, vomiting, sterility, and over time, malignant disease. Evidence from the membranous nephropathy literature suggests that the incidence of cancer is increased at much lower level of exposure than previously considered. Early uncontrolled studies using the calcineurin inhibitor cyclosporin suggest an initial benefit but a high relapse rate. Cyclosporin may reduce proteinuria not only through its immunosuppressive effects but also by direct effects on podocytes. Cyclosporin was relatively well tolerated. However, 38% relapsed within 6 months of discontinuation of the treatment. Significant adverse effects seen with cyclosporin include hypertension, gingival hyperplasia, gastrointestinal complaints, muscle cramps, and most importantly, nephrotoxicity. The latter depends on both dose and duration of treatment. In a 12-month RCT with 48 patients, monotherapy with tacrolimus and alternate CNI was compared with a control group. Proteinuria remission was 76% with tacrolimus versus 35% in control group, and progression rate was also substantially slowed. The relapse rate after stopping the drug, however, approached 50% by the end of 2-year follow-up. In summary, RCTs have been showing that both cyclosporin and tacrolimus are effective in reducing proteinuria in membranous nephropathy, although relapses are common after short exposure, such as 6 to 12 months. A longer exposure time and lower maintenance doses of CNI can be used to maintain partial remission. Mycophenolate mofetil was also considered, but it is showing conflicting results. However, even in the most optimistic studies, although the initial response was high, used in combination with prednisone. The relapse rate within months approached 50%. Another option to treat membranous nephropathy is rituximab. Rituximab has been more popular after Mentor's study showed promising results. In several initial pilot studies, rituximab was found to have reduced proteinuria by 60 to 70%. The response rate to rituximab in patients who previously failed immunosuppressive therapy was similar to patients receiving the drug as a first-line therapy. A delayed response in proteinuria reduction was seen, similar to that with cytotoxic therapy, with remissions continuing to occur up to 12 months after the last rituximab infusion. The anti-PLA2R antibody was measured in Mayo Clinic cohorts, and a decline in titer preceded proteinuria reductions by as long as 3 months and was associated with patients subsequently achieving a partial or complete remission compared with those with no change in titer. Although the first RCT comparing rituximab plus conservative therapy to conservative therapy alone did not achieve a significant primary endpoint of remission at 6 months, anti-PLA2R levels were significantly reduced. This reduction occurred at 17 months, which is important to note again regarding delayed response with rituximab. Mentor study showed similar results reflecting delayed response. These results are consistent with those of prior studies showing that immunologic remission precedes clinical remission by several months in patients treated with rituximab. There are several other agents that have been studied but did not take place in daily use of MN treatment options. Eculizumab is a humanized anti-C5 monoclonal antibody designed to prevent the cleavage of C5 into its pro-inflammatory byproducts. A randomized controlled study in 200 patients with MN that compared eculizumab with placebo during a total of 16 weeks showed no significant effect on proteinuria or renal function, but effective complement inhibition was not achieved. Another agent tried was adrenocorticotropic hormone. 2 small studies have reported the use of an intramuscular long-acting synthetic form of ACTH in membranous nephropathy. The exact mechanism of action of this agent in MN is unknown, but likely unrelated to corticosteroid effects because corticosteroids alone are not beneficial in MN. A dose escalation study showed prolonged remission in the majority of patients with MN treated with the synthetic form of ACTH. Control of proteinuria, specifically achieving either complete or partial remission of nephrotic syndrome, is associated with prolonged renal survival and a slower rate of renal disease progression in patients with MN. Supportive or conservative care should be provided to all patients first, including diuretics, antihypertensive agents such as ACE inhibitors or ARBs, and lipid-lowering agents with lifestyle modifications such as salt restriction, weight normalization, and smoking cessation. In patients with MN who require disease-specific therapy, the choice of agents remains controversial.